there are 35 participants and growing. Okay. Should we wait a minute maybe, or go ahead and get started? Maybe I'll wait 1 minute. All right. I think we'll go ahead and get started. I see a couple folks still coming in, but the session will be recorded for those that want to catch up. So we'll go ahead and get started. Welcome, everyone, to this amazing opportunity for talking about AI in the field of cardiovascular imaging. My name is Peter Chang. I am a radiologist and associate professor at the University of California, Irvine, and I have a fantastic panel of experts with me today to talk about this fascinating topic. Now, before I get started, I'm just going to highlight the ground rules here of the webinar just to get us all started on the right foot. This webinar, as most of you know, will be a total of 1 hour in duration. We'll have a total of 3 speakers, myself included, who will speak for about 15 minutes each. We ask that during the presentations, you refrain from asking any questions live. You will be able to post comments as we go, and in the background, we will accumulate those comments and questions and try to address them at the very end in a short 10 to 15 minute Q&A. These are our speakers for today. So as I mentioned, I will lead us off here shortly with an overview of the topic and some of the opportunities in the field of AI and cardiovascular imaging. I will then invite my 2 colleagues to continue on. Dr. Erik Ranschaert, he is a visiting professor at the Ghent University in Belgium, and he will be talking to us about sort of the clinical value and key implementation strategies to make artificial intelligence work in your own practice. And he will be followed by Philippe Grenier, former professor of radiology and chairman at the Sorbonne University in Paris, France, who will be highlighting some of his own specific hands-on experience with several of these tools in his own clinical practice. Erik, unfortunately, will need to leave immediately after his presentation. So myself and Dr. Grenier will stick around for those questions at the end. But if you have questions for Erik, please go ahead and hold on to those, and we'll make sure to forward them to him and connect you to after the conclusion of the webinar. And as I mentioned, the webinar itself is recorded and will be available after the session today. All right. With that, we'll go ahead and get started. So I'm going to talk a little bit about an overview of this topic, trying to understand the key needs and opportunities of artificial intelligence and cardiovascular imaging. From the background of a software developer and some sort of a more technical expert, I want to talk about the types of tools people are using and the types of tools you can expect to see, as well as highlight a little bit about where the future in this field might hold. As we all know, the key to adoption and the key to real benefit of this emerging artificial intelligence technology is the ability to deliver value to our patients, right? To address specific key needs. And in our world of cardiovascular imaging, this comes in a number of ways. As many of us know, for the radiologists and clinicians on the line, we're facing ever increasing imaging utilization volume. This comes not just in the total number of exams that you need to interpret per shift, but in fact, each individual exam is becoming more complicated with more images, more complexity of data, and increased rigor of interpretation new guidelines and sort of emerging standards that require us to extract ever more information from the images we acquire. Related to this is the idea of resource allocation and prioritization, right? You're typically facing limitations and which patients you can address and engage first, and the need to find and identify key needs quickly is another major challenge that we face. And at the end of the day, much of what we do in radiology is manual, right? The fact that we need to actually go through these thousands of images and identify the abnormality and then to quantify it in some way, to measure it or to document it, and ultimately interpret what we see on the images. Now, certainly much of this will ultimately require the expertise of a trained human expert, but much of this can also be augmented and accelerated with the use of machine learning. In the following few slides, I'm going to highlight key categories and types of tools that we can expect to see with sort of an overview of both the benefits and then the types of applications that are coming into the market. The first and perhaps most popular category of tools is in the realm of work list prioritization. Here, the key benefit or value added is the ability to effectively triage resources, right? You have a list of 20 or 30 patients and you don't actually know which one of these patients needs your attention first. This is a key example of resource allocation. You'll also notice that for most of these examples, a key benefit is the ability to decrease time to treatment. There are many diagnoses we encounter in the real world that, quite frankly, don't require an immediate intervention. And so while those type of priorities can in fact be very useful, they'll sort of show up in different categories that we'll see. Perhaps pulmonary embolism is one of the most popular examples of this type of application to quickly identify patients with acute PE and triage for potential intervention. You might also imagine similar key interventions that are available to repair an aortic dissection urgently, or to perhaps insert a chest tube in a patient with pneumothorax, or even to readjust or maneuver existing support devices if a particular endotracheal tube is too deep into the airway, or a central line is not deep enough into the central vasculature. Here's, again, a classic example of a patient who comes in to the emergency room with a concern for pulmonary embolus. Now, despite the strong clinical suspicion, as in many hospitals, this patient may nonetheless wait 2 to 3 hours before the original images are actually interpreted, just due to the extraordinarily high volume of patients in the ER and the inability to actually know which patients need engagement and interpretation first. Here, with the use of machine learning, we see that interpretation speed for positive cases is significantly reduced, oftentimes reported in less than 10 or 15 minutes from the original acquisition. As clinicians, we're usually very confident in the ability to detect PE, and by and large that can be true. But this slide emphasizes that in fact, there are a small but non-trivial number of cases, up to 15% in our cohort, which are missed, just because you're very busy and you may not be able to look at the images with as much detail as you would like. And the ability or the benefit here oftentimes of machine learning is to bring down that miss rate, again, in our reports, as low as 3 or 4% of the whole population. Another major category of applications is what I will call or define assisted diagnosis. So these are things that either radiologists don't really do well. They're not things that we naturally look for in an imaging study. And so the key benefit here is the ability to augment what humans do well. Another major category is that of non-targeted evaluation. So there are things that radiologists perhaps could look for if they had enough time, but just due to time pressures, they're not going to be paying attention to that particular outcome. Cancer radiomics is probably the most perhaps salient example of augmented diagnosis. Here, we oftentimes can leverage very subtle findings, things like the tumor texture or internal heterogeneity or other high-level deep learning features to predict histologic subtype of tumor or patient outcomes or amenability to certain therapies. Again, things that are not very easy for radiologists to quantify currently. Another major, perhaps interesting use case was early in the COVID pandemic, right? The ability to identify findings characteristic of COVID in a sort of new pandemic setting was difficult for folks that just didn't have a lot of exposure to the disease. These are things that we now know many years later, but early on in the process, the use of machine learning can certainly help augment that workflow. In terms of non-targeted evaluation, incidental PE is perhaps one of the most popular and common use cases. Here's a classic example of a patient who is obtaining a routine follow-up chest CT for the purposes of cancer workup, right? So someone for whom PE is not necessarily expected and not something that the clinician is actively looking for, and as a result, something that is oftentimes missed by an interpreting radiologist. But in fact, in this patient with cancer and with thus a high risk of thrombotic events, there was in fact a PE that was only caught retrospectively after the application and augmentation of machine learning. The third major category I'll point out is that of disease quantification. Here, the primary benefits are to automate the measurement of some entity. It turns out that while the initial exam for workup of a disease process is a true diagnostic dilemma, almost every other follow-up exam that we obtain is interested in just trying to understand change in disease. And that's where these automated measurements have a potential tremendous value for impact. In addition to automating and just making this process faster, we ultimately get more information, right? Quantitative 3D volumetric measurements have always been possible. They're things that are technically visible on the image, and with enough sort of patience, humans can do these same measurements as well. It's simply not practical without the aid of machine learning. Again, cancer, tumor, and cancer volumetric follow-up is a very common scenario, but I would also emphasize that all of the cardiac chamber measurements on an MR exam, all the segmentation that actually used to be manual just a few years ago, is now almost universally automated by machine learning and deep learning tools. Similar applications can be seen in automated coronary artery calcification measurements, and slightly more experimental or future tools looking at COPD lung measurements, understanding the thrombus burden in PE to help gauge likelihood of intervention success, and so on. Another category, and something I did mention briefly in an earlier slide, is that of incidental screening. Here, the idea is that after an exam has been obtained and after some acute finding or acute question has been addressed, can we maximize the amount of imaging data that's available on the rest of the study? And to some extent, this type of problem has been linked with relatively new and interesting population-level insights that we've long suspected but have never really been proven. A classic example here is in the case of osteoporosis and bone mineralization measurements. A chest CT, which is again oftentimes ordered to evaluate acute pathology, pneumonia, heart disease, in fact is also a study where all your thoracic vertebrae are visible. And it certainly would make sense that the density of your bones on that study correlates to your likelihood of, again, decreased bone mineralization, osteoporosis, fracture risk. But it's not really something anybody studied until about a decade ago. And you did a simple measurement here at certain vertebral body levels and correlated that value to known sort of DEXA scan outputs. And once that relationship had been solidified, we could then start using these routine CT exams to do that exact same type of screening that we used to have to order an entire different study for. We're seeing similar efforts in the field of coronary artery calcification, particularly on these non-gated studies, again, studies for which the heart is actively beating. So you don't have as much high quality information as you would in a standard dedicated heart study, but nonetheless, enough information to still extract a lot of very useful and interesting data. On the horizon, we have tools that look to measure and quantify risk for development of aortic aneurysm, valve disease in the heart, vascular quantification as a biomarker for all sorts of disease processes, as well as just looking at, for example, the total amount of adipose fat you have in your body. Again, risk factor for heart disease and stroke, and many other downstream complications. The final category I'll point out is that of image quality and workflow. Here, the primary benefits now relate to the ability to acquire your data faster, to decrease the scan time through accelerated imaging, or perhaps taking data that you already have and making it less noisy or improved in resolution. Here's also another example of automated and dynamic protocols. So the ability to take a very complex cardiac MRI, and rather than having a technician manually prescribe all the required views, to in fact have that prescription be performed dynamically and automatically without human input. And finally, of course, all these improvements may lead to improved interpretation speed. Here, I think my team here has a video that they might be able to pull up simultaneously, which essentially shows the ability of a user to go through and manually program in specific views. So rather than requiring your technicians generate the perfect obliques or reconstructions, particularly double obliques of certain vessels here in the neck as an example, these can in fact be performed dynamically and automatically by machine learning algorithm, as long as the user, again, sort of defines what they need just once on a 3D volumetric study. All right, in the last minute or two, I want to highlight some of the trends for the future of artificial intelligence, particularly from an algorithm and development perspective. As many of us know, AI is currently very difficult to make well. It's hard to obtain broad generalizability across multiple hospitals. The applications tend to only focus on one very specific narrow use case. And as a result, it's very hard to induce these algorithms to evolve, to get better, to grow over time. Almost all of the new development in AI in the year 2024 is actually focused on a different paradigm. It's a paradigm focused on foundational modeling without the use of labels. So allowing models to go through large cohorts, completely uncurated by humans, and to simply extract whatever patterns naturally exist. ChatGPT is a perfect example of this algorithm. It was trained, again, with minimal human supervision, without one specific task in mind. But as many of us know, after training, we can end up using that model for almost anything that we want. We can ask it any type of question without ever having to, again, explicitly train or condition the model to address that use case. Such models may ultimately one day facilitate continuous learning in a much shorter development cycle, a much more active type of model compared to the technology that we're using today. All right, and with that, my 15 minutes are up, but as I mentioned, we'll be back at the very end for a quick question and answer, so hold on to your notes. We'll address them at the end, and I will turn it over to my colleague, Erik.
All right, thank you very much, Peter. That was a great presentation and an excellent overview. So I will try in my presentation to give a better insight in the clinical value of using AI, but I will give the example of detection of chest nodules and detection of lung cancer. And I will also use that to illustrate the challenges and the limitations which still exist around the acceptance and implementation of AI. And then, of course, I will continue with giving you some advices and recommendations. Next slide. Yes, so the key problem with lung cancer in Europe is still the fact that Oh, I'm sorry, I'm giving the wrong. It's still the fact that it is, let's say, characterized by a high mortality rate, which means that it's still the leading cause of cancer death in Europe. And this is about 18% of all cancer deaths. Another problem is that late stage diagnosis, which means that 70% of these lung cancers are detected at an advanced stage, which also reduces the treatment options and the survival rates. So only 15% of patients with lung cancer are still alive after 5 years. There's also still a lot of health disparities, which means that there's a variability in the healthcare access and the quality between the countries and regions, which also impacts the early detection and treatment options. And as you know, and as also Peter said, we are confronted with overburdened healthcare systems, which means that there's an increasing demand on radiologists and oncologists due to the rising number of patients and complex treatments. And then, of course, another issue is the low acceptance of screening. Despite the evidence of its effectiveness, the lung cancer screening programs are not yet widely implemented across European countries. I will say more about it in the next presentation, in the rest of my presentation. So yes, what are the advantages of chest CT for the early detection of lung cancer? First of all, with CT, we can identify small nodules, which means these are nodules that can be missed on chest X-ray. And these are nodules of about 2 to 3 millimeters. Then we can also assess the nodule characteristics, which is the size, the shape. We can detect calcium, and we can also differentiate between benign and malignant nodules. This allows us to do this in a more efficient way. We can also recognize subsolid nodules. So this is quite important for identifying adenocarcinoma in the earliest phase, but there's still challenges in accurately risk stratifying these nodules, and ongoing research is still going on also with AI applications, but they hold promise for enhancing the detection and management of these subsolid nodules. The nodule growth can also be monitored with CT, so we can follow up patients by repeating scans and detect changes in size or appearance. We can use CT to screen high-risk populations, for example, smokers or those people with a family history of lung cancer. And yes, we can do early-stage cancer detection with CT, which means that the modality can help us identify lung cancer before the symptoms develop, which also improves the diagnosis. Next slide. So using CT for screening, well, it said that this helps us reducing the cancer, the mortality with about 20 to 25%. These figures are based upon trials that have been performed earlier. The NLST trial, this US-based trial from 2011, showed that the CT screening reduced lung cancer mortality by about 20% compared to X-ray screening. And then there's the European, actually Belgium, Netherlands, Nelson trial from 2020 that showed that 24% reduction in lung cancer mortality could be obtained with CT screening. The volume-based screening and growth rate assessment method proved very effective to identify lung cancer. The low-dose CT scan is a test that is currently seen as the most effective for finding lung cancer at an early stage. And regarding the screening that is currently performed, well, in the US and China, they offer screening for lung cancer covered by the national health systems, but also in Europe, countries like Netherlands, Germany, the UK, Poland, and the Czech Republic, they offer screening in some locations. At this moment, the European Respiratory Society and the European Society of Radiology, they are both collaborating and calling for action to implement national screening programs across Europe. Next. So, what is the potential of AI in lung cancer screening with artificial, in lung cancer screening? What can we do with AI? So, for nodule detection, the AI which is also called aided diagnosis or CAD, computer aided diagnosis, is used or can be used as a second reader, and it shows that it has been shown that this yields superior performance when comparing the performance of a radiologist alone. So what also has been found is that AI reduces the inter-observer variability of the nodule metrics. And of course, the use of AI leads to higher sensitivity despite a relatively high number of false positive findings. And automated lung nodule detection using AI is relevant in lung cancer screening because we have to maximize nodule detection. Next slide. So I will show you some results from a master thesis that has been done by one of my medical students in Ghent, and I'm quite happy that the medical students already start doing this kind of, or treating this kind of subject in their thesis. So in this review, several algorithms to detect or classify pulmonary nodules have been analyzed in terms of their efficiency and accuracy. These were both, it was a mix of commercial and non-commercial models. And in this work, it was discussed how the AI could be implemented in the context of lung cancer screening and what the risks and the remaining challenges are. Next. So first of all, I have to tell a few words about how humans can collaborate with AI. First, typically a collaboration is sought, of course, between the radiologist and the AI application. And then the program can play a supporting role for, as Peter already said, detection or measurement or classification of abnormalities. The AI can fulfill this supporting role in several ways. It can do this as a first reader, and this is certainly when we talk in the context of screening, but so the AI can read the images as the first reader. It could also work as a second reader or as a concurrent reader. And AI could additionally also help in comparing with old data and thus chart the evolution of disorders faster and better. Next slide. So when we speak about AI reading as a first reader, it means that the AI gets to see the case first, independently, and then extracts the findings which need to be validated by a radiologist. So as a first reader, the AI could filter out all normal scans or normal chest CTs, for example, and ensure that the second reader only has to look at the abnormal scans, which, of course, would mean a significant workload reduction, especially in the context of screening. AI can also be used as a second reader, which means that the AI analyzes the images after the radiologist. So in this setting, AI could raise findings that the first reader didn't see. So this way, we could reduce false negatives. And AI could also suggest to reclassify findings. For example, if a radiologist classified it as benign, the AI could see, maybe you should look at it again. And then AI is a concurrent reader. So radiologists and AI, they get simultaneous access to the images. And in this way, the radiologist could get additional information from AI while he's reading the case, or the radiologist, and that's a danger, I think, the radiologist could be biased by seeing the AI results immediately. Next slide. So this is what the analysis of the from a medical student showed when comparing the sensitivity of AI compared with a radiologist. As you can see here, in all these publications, and he analyzed more than 29 publications, the AI was using AI had a greater sensitivity for detecting these abnormalities. Next slide. So also for the classification of lesions, the AI shows in general a greater sensitivity, and the false positive rate, as I said, it remains significantly higher compared to that of a radiologist. But some studies do suggest that the number of false positives has already decreased to such an extent that validating the false positives would have no real significant impact on the radiologist's workflow. Next slide. So what is also the limitation that have to be mentioned, the limitations of AI studies? Well, AI models used in scientific papers are difficult to compare because there's a lack of universally used validation data set. So the effective accuracy of an algorithm in a general clinical setting is still difficult to determine because we don't have such a generalizable validation dataset. So this means that a more standardized methodology should be followed for analyzing and describing AI models, including specific parameters in the context of their purpose. Next slide. What are the current trends in AI for radiology? Well, first of all, there's the positive ones. AI models, they are improving in both detection and classifications of abnormalities such as lung nodules. And also positive is that some studies show AI outperforming radiologists in certain comparisons. And there's also a reduction in processing and reading time, up to 22%. We see that there's fewer false positives in the new models, but the false positives are still higher than when a radiologist is reading the images by himself. What are the negative trends? There's a lack of standardization in reporting and AI model performance. There's still limited studies about how to best implement the models in clinical setting, and there's limited numbers of comparisons with human performance. So what we need is actually large-scale prospective studies to validate AI model implementation in clinical practice. Next slide. So some tips for implementing AI in clinical practice. First of all, you have to do some critical assessment of the training and validation datasets that were used for each model. You should examine, of course, the formal CE certification. That's the case for Europe. Examine the compatibility with the existing IT infrastructure in your hospital. How will this integrate? Is this feasible? Can we implement this in a seamless way? The fourth tip is assess purchasing and running costs. Don't forget that there's also costs involved in maintenance and monitoring of the solution. Do plan the training of the users, because you have to safely use these applications in your clinic. After implementation, you should confirm that the AI product is working as planned on a regular basis. So you have to do some audits. There's even some audits available from the Royal College of Radiologists, but now I'm talking about lung cancer screening. You also have to implement a system for providing user feedback and to do regular checks. Plan for the negative effect of AI on the training of new young radiologists, and also consider the ethics and transparency towards patients. Next slide. All these tips are provided in this excellent paper, which is written by a radiologist specialized in chest imaging. Next slide. And the last tip I would like to give you is the new book that will appear in 2 months, in November. It's about all practical information that we can give you about implementing AI in radiology. And I think it might be very useful for you if you want to use AI in clinical practice. I thank you very much. Yes, so now we go to the next speaker, which is Philippe Grenier.
Hello everyone. Thank you, Erik, for your nice presentation. My objective to report the results of SINA PE usage at Foch Hospital, and to discuss AI opportunity about incidental findings, particularly in lung cancer screening program. Several AI solutions have been developed to improve the diagnosis of acute pulmonary embolism on CT pulmonary angiography, CTPA. As you know, the pulmonary embolism is the third most frequent cause of acute cardiovascular disease events. Prompt recognition of acute PE and immediate initiation of treatment can reduce the risk of death, and the most common cause of death from PE is a failure of diagnosis. Pulmonary CT angiography, CTPA, is a non-invasive, widely available and rapidly performed modality that has become the gold standard diagnostic tool for PE. And as I told you, recent good results of deep learning models have been developed to automate PE diagnosis on CTPAs. Most of the published evaluations of the diagnostic performances of these solutions for diagnosing acute PE on CTPA were focused on the AI standalone performance. For example, in this large retrospective multicentric study, including more than 1,200 patients, diagnostic performance of a validated AI algorithm of PE detection on CTPA was compared with that of radiologists in a clinical setting. Sensitivity and negative predictive value of AI were higher than with radiologists, although the differences were not statistically significant. Specificity, positive predictive value, and accuracy were significantly higher with radiology than with AI. However, in this study, there was no comparison of radiologists' performances with and without full access to the AI output. Other studies have compared the radiologists' performances before and after implementation of AI in the department, but they don't use the same patients, and they don't use the competencies of the same radiologist. That's why we perform a study evaluating the radiology residents' performances with and without a deep learning-based algorithm. 230 pulmonary CTPA were randomly selected from the packs. 23 were excluded because of presence of lung pathology, of incomplete chest scanning, or presence of artifacts. And finally, 207 CTPA were anonymized, uploaded, and processed by SINA-PE. Yes, we use the SINA-PE AI software from Avicenna that was trained, tested, and validated on the multicentric real world. Analysis failure by SINA-PE was observed in 11 cases, so finally only 196 CTPA were included in the analysis. 2 board-certified senior chest radiologists reviewed to consensus the pulmonary CTPAs. And these 165 CTA were negative for PE and 31 CTPAs were positive for PE. And 3 radiology residents interpreted the anonymized CTPAs without the aid of algorithm, then repeated the interpretation 2 months later with the algorithm. And they were asked to answer the main question of acute PE presence or absence with a confidence level scale. First of all, the consensus reading allowed to measure the standalone diagnostic performance. The area under the ROC curve was 0.944 with very good sensitivity and negative predictive value and good specificity and accuracy. The software generated 1 false negative and 11 false positives, including low contrast in the pulmonary vein, hilar lymph nodes, beat artifacts, and so on. Next, the results of resident diagnostic performances. The ROC curve from readings without AI in red color was compared to the ROC curve from readings with AI blue color. There was an improvement of residence diagnosis when using SINA-PE software. This improvement was mainly related to area under the ROC curve, sensitivity, and positive predictive value. Let's see some examples. The PE detected by SINA-PE are marked by red boxes. A clot within the right lower lobar pulmonary artery detected correctly by all residents. B and F, pulmonary embolism missed by the 3 residents. C and E, pulmonary embolism missed by 1 resident. D, segmental PEs in the right lower pulmonary arteries missed by 2 residents. J, hypoattenuation in the right upper lobar pulmonary artery missed by the residents, considered as an artifact by the consensus reading due to high contrast in the superior vena cava. And H, segmental PE missed by the software and the residents. Other results of the study: the inter-resident agreement concordance improved with SINA-PE with a kappa value of 0.88 over without SINA-PE with a kappa value of 0.77. Among correct residents' first readings, 33 were incorrect at the software results, but remained correct at the residents' second reading. The residents resisted to the software false positive suggestions. Among incorrect residents' first readings, 78 were correct software responses, and 70 became correct at the resident second readings. So in conclusion of this study, we can say that an AI algorithm previously trained and validated on large multi-center data can improve radiology resident diagnostic performances at identifying or excluding P on CTPAs. Such improvements might be greatly welcome when residents are the first-line interpreters of CTPAs ordered for suspected acute P before controlled reading by a senior radiologist. Other deep learning algorithms have been developed for detection and triage of cancer-associated incidental P. In a retrospective single-center cross-sectional study, adult patients with cancer were included either before or after implementation of an AI algorithm for IP detection and triage on thoracoabdominal CT scans. The prevalence of incidental P was significantly higher after implementing a deep learning algorithm, and report turnaround time and time to treatment were significantly shorter after AI implementation. So an AI algorithm can increase the detection rate of cancer-associated incidental P and decrease the report turnaround time. And Avicenna have also developed a SINA-IP algorithm to detect unsuspected P not following a dedicated CTPA protocols. In a retrospective multi-center blinded study, including 197 CT scans, the PE were missed in initial rates, and 5 of these missed were detected by the algorithm. In addition, SINA-IP could have reduced the time to diagnosis for these patients. So now move on to lung cancer screening using low-dose-CT in smokers and former smokers. We know now that AI demonstrates significant potential improving nodule detection sensitivity, reducing false positive rates, and classifying nodules, also showing value in predicting nodule growth and pathological typing. But we know also, and we have known that recently, that AI algorithms can also provide simultaneous assessment of smoking-related comorbidities. We are currently using an AI solution made of several algorithms running in parallel to detect pulmonary nodules and also to quantify smoking-related comorbidities. This AI solution is named AI Rad Companion for the Chest, developed and commercialized by Siemens Healthineers. We see an example. We have 3 solid nodules detected by the software. And you have automatic display on axial images with automatic segmentation of the nodules, and the red color of the contour of the sun permits to verify the quality of segmentation and the quality of measurements of the dimension of the nodules. And we see here calculation of the 2D and 3D maximum diameter and volume of the nodules in millimeter cube. But at the same time, the other algorithm running in parallel might detect smoking-related disease. These comorbidities detected by the software include emphysema extent, coronary calcium score, and osteoporosis. Emphysema extent is associated with greater risk of lung cancer. There is many smokers having significant emphysema on CT scan despite a normal spirometry. Coronary calcification provides cardiovascular risk prediction similar to Agatston scores derived from Ghent scans. And smokers and COPD patients are at risk of osteoporosis. Quantitative bone measurements from chest CT scan can estimate the potential for osteoporosis-related fracture risk from chest CT scans. And the bone density measured on the vertebral body on the sagittal formation equal to 90 or less Hounsfield unit is criterion to diagnosis osteoporosis on CT scan. And in a series of more than 4,000 participants in lung cancer screening program, Regan and Associates found new diagnosis of cardiovascular disease, emphysema, and osteoporosis in 25, 7, and 46% respectively. So they conclude that lung cancer screening CT scans can potentially facilitate diagnosis of these smoking-related diseases and provide an opportunity for treatment or prevention. Let me give an example of ARAD companion of the chest. This is automatic detection and quantification of emphysema. We have automatic segmentation of the contour of the lungs and the lobes, automatic calculation of lobes and lung volumes, automatic segmentation of the Foch cells having a density value less than minus 950 ounces, representing emphysema, and they calculate automatically the percentage of volume per lobe and per lung occupied by emphysema. The same software permits automatic detection and quantification of calcification in coronary arteries, then automatic segmentation of the heart, calculation of the volume of the heart, segmentation of the calcification of the coronary arteries with volume of the calcium arteries, and with gradation. The grade 1 is 0 to 10 millimeter cube of calcium, grade 2 from 10 to 100, grade 3 from 100 to 500, and more 4. Grade 4 is more than 500. This is an example of grade 4 with this volume of calcification. We see other example here, grade 4, grade 3, and grade 4. This software may also permit the automatic labelization of thoracic vertebra on the sagittal formation with automatic measurement of the bone density in the vertebral bodies and automatic measurement of anterior, mid, and posterior heights of the vertebral bodies, permitting to detect compression fracture, like in this example on the right side. This is not a red companion. This is an example of a software developed by Avicenna called SINA VCP Quantix. And the ARAD companion permit also at the same time automatic measurement of aortic diameters. We have the measurement of the diameter reconstructed strictly perpendicular to the central axis, valsalva sinus level, sinotubular junction, ascending aorta, aortic arch, aortic descending aorta. And we see in this example a detection of an aneurysm of the ascending aorta. And all these results are obtained in 17 minutes. Automatic in the PACS, you have all these results, detection and measurement of the nodules, emphysema, coronary calcifications, aneurysm of the aorta, extent of calcification of the aorta, and the measurement of the height of the vertebral body, and the osteoporosis by measurement of the bone density. So, in conclusion, AI algorithms that provide a second reading for lung nodule detection and simultaneous assessment of smoking-related comorbidities could increase radiologists' confidence, shorten turnaround time, provide better patient outcomes, and reduce costs by improving disease prevention in this high-risk reputation. So this raises the following question. Could the double reading of low-dose CT scan in the lung cancer screening program be replaced by a single reading supported by an AI solution? To answer this question, we have started a retrospective study using 400 low-dose CT scans from our lung cancer screening program. The scans are read by 2 independent and blinded radiologists without AI. 4 weeks later, the same radiologists will read the same CT scan using the AI RAD companion software. The procedures will be repeated with 2 other chest radiologists. We will compare the radiologists' performances with and without AI for detection of pulmonary nodules and comorbidities, and the radiologist concordances with and without AI will be compared. And finally, an article just came out in the last issue of Radiology this month, in which the authors reported on the performances of a machine learning approach to detect interstitial lung abnormality in low-dose CT scans from the Boston lung cancer study. This is another smoking-related comorbidity potentially predictive of lung fibrosis that we have in the future to take into consideration. Thank you for your attention, and I'm ready to answer your questions.
Thank you so much, Philippe, and Erik as well, who had to take off. Those were clearly extremely detailed and very informative and interesting and provocative discussions. And to be quite honest, if the content itself was not entertaining and interesting, I will say the fact that each presenter spoke for precisely 15 minutes, exactly what we had asked for, is surely a sign of their high level of trading in this. So anyways, thanks for everyone. We have a couple questions in the chat box. I'm going to read them off here. I think the first one was aimed at me, but Philippe, if you have a comment here, please go ahead. The question is, what do we think about virtual endoscopy? And probably I think what they mean is maybe virtual bronchoscopy from high resolution CT images as a useful new modality. I think it was initially posed to me because I had emphasized the fact that our imaging is so detailed now that we can extract all sorts of information that we probably weren't really looking for, but in fact is present on the images. The tracheobronchial tree, certainly on our high resolution CT images, is very easily characterized and evaluated, and then taking the raw data and creating 3D reconstructions of that data makes absolutely sense. We do it all the time for other body parts. Virtual colonoscopy in the abdomen, for example, has become very popular. So I absolutely agree. The information is there. Why not take advantage of it? Now, certainly the biggest problem would be that should we start doing virtual bronchoscopy routinely from every raw original CT case we get from the ER or something, right? Certainly that will be overwhelming to interpret. And that again sort of highlights the value of machine learning or these automated methods to at least triage and sort of maybe make some high level evaluations. And maybe if an abnormality is flagged, then that would be reviewed by an expert. But certainly I think that theme and that sort of the underlying ethos of that question certainly makes a lot of sense. I don't know. What do you think, Philippe?
Yeah, may I intervene on these questions? My experience in virtual endoscopy is very marginal. This, my view, is particularly useful when you have mild abnormality on the tracheobronchial trees in a diffuse airway disease, but not really in a focal lung. In a bronchial obstruction, virtual endoscopy has no role at all. So the only way I was very happy with virtual endoscopy when I have a difficulty in saying all the contour of the trachea and the main bronchi and lower bronchi are regular or irregular. This irregularity is real or not. This is a good point. But on the other hand, if you use deep learning on virtual bronchoscopy, that'd be great to detect some focal bronchial obstruction missed by the radiologist. This is another point. It's not virtual endoscopy. It's a deep learning to detect bronchial obstruction. This may be very interesting.
That's a great point. I mean, so we talk about virtual bronchoscopy as a 3D reconstruction because that's how pulmonary experts are used to looking at that. But you're right. The need to take the raw data, reconstruct it in a way that humans are comfortable with it, and then feed that to a machine learning algorithm seems superfluous. We should just give the raw data and ask a model to predict some underlying pathology. That makes a lot of sense. Another question to you, Philippe. So I think you presented some very compelling evidence for machine learning and AI to augment a less trained expert in the interpretation of pulmonary embolus. But what about yourself? As a true expert, is there any role for machine learning to help you interpret the images? And if so, could you provide any examples?
No, really. For chest radiologists, detecting an acute pulmonary embolism on a CTPA performed because of suspicion of pulmonary embolism, the AI doesn't bring any additional information. It's a different for the radiologist residents in radiology, of course, because they have to train. That we demonstrated that the benefit using AI for training residents in pulmonary embolism and CTPA.
Yeah.
On the other hand, the deep learning, even for chest radiologists at the incidental PA software may be very helpful because, in thoracoabdominal CT scan performed in oncology, doing a lot of thoracoabdominal CT and even following cancer patients, and we missed easily pulmonary embolism. That's why in this case, SYNAP is very helpful for detecting incidental PA.
Absolutely, I agree. I mean, in my own personal, I completely agree with that. As a trained expert, you're oftentimes going to be performing better than the algorithm. That being said, sometimes after you read a case, if you have a sort of this second look little checkbox, there's one or two flags that come up and you just quickly look at those, it does give you a little bit of confidence. Yeah. But I agree that the effect for an expert may not be very high. I think the last question here relates to AI for interpreting subtle or early stage abnormalities. How good and reliable is AI in this type of task? And then I think the focus particularly is maybe on incidental or non-targeted studies. So a couple things to unpack there. Why don't if you have a comment, you can start, Philippe, and I can follow.
Yeah, I think it's a question for you, Peter.
It is. It's okay. We're just tag teaming them. I will say for me, I think there is definitely a tremendous value in early stage diagnosis. I think we saw a couple examples already. Early stage emphysema is really just how dark are the lungs relative to what they should be. And I have good colleagues who have written papers and shown that sometimes these very, very early stage changes where the lung is 5 or 10 or 20 Hounsfield units darker than it should be, it's very easy to miss if you're not looking for it. And then I would say from a cancer screening perspective, the value could be very interesting. There's been some very compelling work on pancreatic cancer diagnosis and how these early CT changes oftentimes predate the formal diagnosis by 6 or 12 months, but they're just so subtle that there's no way a human can reliably, with high sensitivity, identify these findings. So you might imagine on a chest CT, when you catch that corner shot of the pancreas, you're not really going to be looking at the pancreas with that much detail, but allowing a machine learning algorithm to then very focus in a very focused way evaluate for something like cancer diagnosis. I think there's certainly a lot of potential value for that one. Anyways, I guess there's a couple more that keep coming in, so I'm just going to keep throwing them out there. So one question is, how do we incorporate new AI strategies and tools into clinical practice, acknowledging that while there is value, it oftentimes comes down to a question of cost and whether the cost for the new thing we're getting is actually worth it. What do you think, Philippe? What's your experience there?
Yeah, but the cost, it depends how to finance, how to pay the cost of AI when you have the reimbursements by this administration for an examination. If the cost is not included, if the cost is additional cost, the radiologist will be very reluctant to use AI, except in when the benefit is huge. The problem is for the development of and the clinical application of this AI software depend on the way how the payment will be organized. Who will pay for that?
That's right.
The patient, the administration, Social Security, or the radiologist?
That's right. I mean, there's a very interesting comment here that I see that points out a lot of the things we're proposing. By extracting more information, you're actually causing more work, right? You're increasing the burden of reporting on behalf of the radiologist, and now the referring clinician has to sit down with the patient and maybe spend another minute explaining this new finding or this new thing that would have otherwise probably been ignored. From a cost perspective, I'll respond by saying, while that certainly puts the onus on the physician to do more work, as a hospital, you actually tend to make more money because overall you're actually starting to utilize more of the hospital services. You have more referrals to endocrinologists who manage osteoporosis, or you have increased referral to vascular surgeons who know how to treat additional aneurysms. So I agree, it is a balance, and certainly while you have more work on one side, sometimes the cost is made up, there too.
Of course, if the software permits to save time, maybe the radiologists will be interested in use it.
Yes, that's right.
It's a good point.
there's like conflicting, conflicting goals or interests. Anyways, I think we are a minute or two over time, so we might have to cut it here. But there's a lot of great discussion, and I think, again, comments out there in the chat box that I haven't had a chance to look at in detail. So, I see. Does anyone in Avicenna want to talk at all about the roadmap here? Or, as many of you know, Avicenna, the host of this session here, works in a large portfolio of radiology deep learning tools, including cardiovascular, applications, but many across neurovascular musculoskeletal problems as well. So certainly take a look and check out some of these products. And to be completely fair, I mean, there are a lot of vendors and a lot of folks working on this field. There's a lot of unanswered questions and a lot of work that needs to be done. So certainly if something you heard today piques your interest, I encourage you to learn more, to read about what's out there, and to perhaps, give it a shot. Try one of these applications out in your own workflow and see if there's any benefit. And our team, folks to get in touch with. Again, myself and Philippe, I'm sure we're happy to chat with anyone who has questions, and certainly reach out to the folks here at Avicenna if anything comes up.
Thank you. No.
Thanks a lot, team.
Thank you. It was a pleasure.
Same. Absolutely.